Good morning. My name is Zannos Grekos. I'm an interventional cardiologist. I got involved with stem cell therapy about 3-4 years ago when one of my patients wanted to go to Thailand to have it done, and I couldn't pass up a trip to Bangkok, so I went, and it turned out to be the most incredible thing I've ever done, and the medical therapy behind it wasn't bad either. This is a picture of Santorini. It's an island in the Mediterranean. It's absolutely phenomenal. But I put this slide up mainly because when I speak to medical students and to residents, I use the sunrise over the island to illustrate that this is truly a dawning of a new era. And what I really like when I speak to the young physicians or the medical students is that they get it. When we went through medical school, we were told stem cells didn't even exist. You know, it was bone marrow transplants, and that's about all we had. But now, these young physicians, they're growing up in the era of stem cells, and it's very exciting for myself and as it will be for all of us. Title of the talk, and let's see, Regenocide Therapeutic is the company that I'm director for. We have a collaborative agreement with Regenitech. We're going to be using their bioreactor that was developed on the Mir space station. It's a microgravity reactor, so that we can actually tissue culture stem cells three-dimensionally and potentially actually replicate solid organs. The MyoCath injection catheter is BioHeart. That's a Florida company, and it's an injection catheter that injects directly into the myocardium. And then the Regenocides are the cells that are being produced currently in Israel, soon in Florida. All right, that's my titles. And we actually have students from Nova Southeastern rotating through our facility and actually participating in our stem cell clinic. So we've been moving along. I first spoke, I think, about a year ago for the A4M and then for other organizations as well in meetings. And things have changed a lot in the last year, so hopefully I'll be presenting that information to you today as well. All right, what are we looking to do? Using adult stem cell therapy, because when you take all the controversy out of it, this is the stuff that really works, that has the least side effects and is easiest to use, and to treat things that we haven't been able to treat before. Give you an example. As you know, diabetes, there's about 18 million cases in the United States. 6 million patients have diabetes. They don't even know it, so that you can add another 6 million to this, and it's going to be doubling as time goes on. Congestive heart failure is the biggest ticket item for Medicare as far as expenditures go, so we can actually save billions and trillions of dollars, and those are real numbers for Medicare as time goes on when we're using stem cells to keep these patients out of the hospital. And I'll show you those numbers as well. All right, sources of stem cells. We have non-embryonic, and then we have the embryonic. The embryonic, there's been about 20 years of research going into it. Geron Corporation just got approved, what was it, about 2 months ago, 3 months ago maybe, for the first human embryonic stem cell trial. It's supposed to be taking part or starting this summer. What they're doing is they're using patients that have suffered acute spinal cord injury within 14 days, and they'll be treating them with embryonic stem cells that have been differentiated into neuronal cells. The reason they've been differentiated into neuronal cells, and quite a bit differentiated, so they're mature cells. They're not embryonic pluripotent cells. They're mature differentiated cells, is because they have a very high risk of cancer and teratoma. So far we haven't used embryonic for any human treatment, and we've barely had any success with animals without having too many side effects. Because that embryo where we get the stem cells is somebody else, or would have been somebody else, it's a foreign cell, so we have to use immunosuppressives in those patients. So patients being treated, or that will be treated, with embryonic stem cells will have to take immunosuppressive medications. High teratoma cancer risk, and they actually know what the incidence is based on how differentiated the cells are. And when you differentiate the cells, they lose the regenerative properties. So we're actually losing the qualities of these embryonic cells when we're using them in humans, because we're so afraid, and it's a real fear, that they're going to cause a teratoma or a cancer. And of course the controversy. And it's interesting because I get patients that do come in and they want to have stem cell treatment. When I tell them that the cells that we're going to be using they're going to be coming from their own bodies, you see the look of relief on their face, because patients who are sick or terminally sick that have no options want to get better. And for the most part, They don't care where the stem cells come from, but when they find out that they're not embryonic, they don't have to defend their decision to other family members, and they also don't have to live with whatever guilt they may have, if they have that guilt. All right, now, I just added this to the slide, induced pluripotent cells. These are cells that are taken from donors. They're mature cells, such as skin cells or cells from other strata from the body, and they're deprogrammed back to embryonic. So what we're doing is we're turning these cells back into embryonic type cells, which have basically all the problems that embryonic cells have, with the exception of the controversy. So we still have to use immunosuppressives if we use them in other individuals. They still have a cancer teratoma risk. They lose their regenerative powers if we differentiate them forward again. So iPS cells are not all that's expected of them, because they fit very snugly into the embryonic category. All right. Let's talk about non-embryonic, fetal stem cells. And I think that there was a talk earlier today about live cell therapy. Well, those are lamb fetal cells. And we can do the same with human. There's aborted fetuses that are being bought up in Russia and Eastern Europe, that then the stem cells are being extracted and they're being delivered to patients. Fetal stem cells, whether they're lamb or human, do have a benefit because they have a very strong paracrine effect, as you were told earlier. The only problem is that your body will see them as foreign once they start maturing and exhibiting HLA phenotypes, and they'll be destroyed. So we go back to the immunosuppressive needs. Cord placenta, if any of you have children or grandchildren where the stem cells have been saved from the cord at birth, or potentially the placenta stem cells and then banked, that's a very good thing, not only for that individual, but other individuals that may match. I hope and expect that in 20 years, all births, all stem cells will be saved at birth and banked and HLA cross-typed, and at that point we can actually treat metabolic diseases because we can do HLA typing and use healthy stem cells to replace the damaged cells or the dysfunctional cells in the affected individual. Does that make sense to everybody? Okay. I know I'm talking fast. They told me I only have half an hour. This thing's going, the ticker in front of me. So I'm going to show you, there's a lot of information I want to get out to you. All right, and then what I like to call adult stem cells, even though that whole category is really adult stem cells, I really like to use the term adult stem cells and stem cells that come from us. Believe it or not, embryonic stem cells are being used by some groups to denote fetal stem cells. In Europe, an embryo is also a fetus. So there's groups out there saying that they're using embryonic stem cells, but they're really fetal stem cells, and it's a misnomer, and it's misguiding the patients to quite a degree. But we all have stem cells in us. Every organ in our body has stem cells, our brains, our muscles, our heart, bone marrow. We have them circulating in our blood. So what we had learned in medical school 20, 30 years ago, or longer for some of us, is really kind of different now. And we can take these stem cells and guide them into a certain direction of repair. We know that when an individual is young, those stem cells are very vigorous. So if you do cut yourself or have some muscle damage, the stem cells, the resident stem cells in those organs, will be very vigorous in the repair of the damage. As we get older, it's less vigorous, kind of like everything else in our bodies. But what we have learned is if we took, and we did this with animals, if we take an old animal and a young animal, cause damage, the young animal heals much quicker. If we take those two animals, connect their circulation, the old animal stem cells are just as vigorous as the young animal stem cells.